This is an informal talk, sort of. I'm Jessie Wall. I'm a emergency medicine physician, peds emergency medicine physician in Seattle. This is Sarah Cavallaro. Thank you to all my residents right there who are being supportive today. You guys should know all of this. We've talked about it before, but anyway, all right. This is also Dr. Maggie Samuels-Callow, who is my other co-presenter. Dr. Nicole Nadeau couldn't be here today, so we'll be presenting her article on behalf of her. To get us started today, so we selected articles that we thought were practice-changing in the management of pediatric patients in general emergency departments overall, and things that really should be spread throughout the literature. So the first article that we are presenting is the Clinical Practice Guideline Evaluation and Management of Well-Appearing Febrile Infants in 8 to 60 days old. This was published in Pediatrics in later in 2021, and this is probably the most comprehensive guideline out there, helping us manage the febrile infant. To get us started, somehow our slides are missing many pieces to them. Our words are not in. Yeah, these are the most updated. Well, we'll do it without the words. All right, so the methods of this particular study. So this was funded by AHRQ. They did a really extensive literature review. They came up with multiple performance sort of key action items for how to manage this population, and then published this study and really broke it down into multiple sort of guidelines based off of age. Essentially what happened is they took 4 large data sets and completed a meta-analysis looking at the rates of bacteremia in infants, and then determined that there was a sort of natural cutoff between 8 to 21 days, 22 to 28 days, and then after 28 days. So they then developed a guideline based off of that. Do you have it with, I was like, I don't have, looks like this is not the one we uploaded. We'll just keep going. It'll work. All right, we'll do it anyway. Okay, so parts of this guidelines. I'm going to give you guys the highlights. I'm sorry that sort of my bullet points in there are not there, and you probably can't read it beautifully on the screen, so let me walk you through this. So for 0 to 21 days, we didn't change much. The AAP guidelines basically said we're still going to do a full septic workup. So any patient that is up to 21 days of life, they get the full set of blood cultures, urinalysis, urine cultures, lumbar puncture, empiric antibiotics. All those patients get admitted regardless of how they look. That being said, is as we move on to sort of this next group, the 21 to 28-day-old infants, this is where things start to change, and we actually start to guide our management a little bit with inflammatory markers. So when we talk about inflammatory markers, looking at this guideline, we actually are talking about sort of an expanded scope of what we've initially thought. So things like a temperature greater than 38.5, which you're like, well, that's a febrile infant workup, duh. But actually the inclusion criteria into this workup is 38.0. 38.5 and above, there's some literature suggests higher fever has a higher infectious rate for bacteremia, so that's why that's an independent inflammatory marker. Other things that are included in inflammatory markers are an ANC, so not a white blood cell count, but an ANC of greater than 4,000, an elevated CRP, or an elevated procalcitonin. And if you have the ability to do all of these, they recommend doing all of them, or you could select inflammatory markers if you don't have the full set. When you are looking at this 22 to 28-day-old infant and trying to determine if you're going to do this complete workup or not, you start with a urinalysis. Every patient should have a urinalysis, and if their urinalysis is positive, you're going to do urine cultures, they're going to get antibiotics, even though you're going to do the rest of this workup. You're also going to obtain a CBC with blood cultures, and you're going to obtain your other inflammatory markers. If you have elevated inflammatory markers, that patient gets a lumbar puncture, they're probably going to get antibiotics, and they're going to get admitted. If their inflammatory markers are essentially normal, not elevated, then you kind of have some shared decision-making to do about doing the lumbar puncture versus admitting the patient to the hospital for observation. If you decide to not do the lumbar puncture, again, in this sort of small window, those patients should be admitted to the hospital for observation, plus or minus empiric antibiotics, depending on what your urinalysis showed. That being said, if you elect to do the lumbar puncture and you have a normal lumbar puncture, you have a normal urinalysis, and you have negative inflammatory markers, so basically a fully negative workup, those patients, per this guideline, can actually be sent home. Shared decision-making with the family, and they should be given an empiric dose of IV antibiotics before they're sent home. But they can be sent home with close follow-up and with cultures pending, which is a big shift in how this has been practiced across the United States with different guidelines. Lastly, this article talks about those 29 to 60-day-old infants, and this is really guided by inflammatory markers more fully. So these patients come in, they get a urinalysis, they get a CBC, again, they get their inflammatory markers, and we use those inflammatory markers to determine if we're going to do more workup or not. Now, at this point, if you have a positive urinalysis but negative inflammatory markers, the guidelines say you do not need to LP. In fact, you should not be LPing those patients, and those patients should be discharged home with oral antibiotics as long as they're looking well and have close follow-up and a urine culture pending. And this is kind of a shift. These are patients that now can go home and be managed at home with oral antibiotics. Patients that have elevated inflammatory markers, now you have some shared decision-making. Do I want to do the LP or not? If you do the LP, you can use that to guide whether you're going to send them home because it's negative, versus if it's positive, of course they get antibiotics. And if the family declines the LP, you can admit the patient for observation versus sending them home with parenteral antibiotics. So this changes it and makes it actually a little bit more about shared decision-making with the family and really focuses on how we think about this in sort of more of an age risk stratification. So again, 0 to 21 days, or that kind of 8 to 21 days, that's a full septic workup. We've been doing that a long time. The ER doc is great at that. That kind of intermediate window, 22 to 28 days, now you use inflammatory markers to really guide what you're going to do. But those patients pretty much are going to end up either in the hospital or with empiric antibiotics regardless, because it's still a higher risk group. And those patients that are past the 28-day mark, those patients, you really are using your inflammatory markers to guide your workup. And if you have an isolated UTI, those kids should go home with oral antibiotics. They should not get the rest of the workup if they have normal inflammatory markers. So it's basically kind of liberalizing how we manage this and including the family more in our decisions. All right, Dr. Cavallaro is going to give us our next article.
Okay, so to continue on this theme of bacterial infection, what happens now when you have a localized source of bacterial infection and looking for SBI? And so this paper was a pediatrics paper from 2021 looking at this exact question, since this happens to us in the ED a lot, and we all practice a little bit differently. So this was a retrospective cross-sectional study in 28 EDs, mostly in the US, one in Spain, one in Canada, over 10 years. And this was looking at infants 90 days and younger with local mastitis, identified by ICD-9 and 10 codes, and then some chart review. And the primary outcome was presence of SBI in this kid who had a localized mastitis. And the secondary outcomes were ICU admission, diagnosis of sepsis or shock, neck fash, intubation, vasopressors, or death. So this is kind of the meat of the study and the main findings. So there were 657 children over the course of this study that were identified, and these are the positive cultures that came back looking for SBI. So of these children, 88% of them had blood cultures sent. Remember, this was kind of retrospective chart review, so it wasn't a standardized protocol. It was what the clinician decided to do. And less than 1% of these cultures that were sent, or 2 of them, came back positive. Both young kids under 21 days old. Interestingly, neither had fever, and neither were ill-appearing. 33% had CSF sent. 1 came back positive for MRSA, and a 6-day-old who was febrile, so probably would have been caught by those guidelines Jesse just talked about, but was not ill-appearing. And then 42% had urine sent. 3 here came back positive. 2 were febrile, 1 was not. None of these kids were ill-appearing. So our take-home points about SBI in kids with mastitis, 90 days or younger, that all of these kids that come back positive seem to be well-appearing. Half of them were afebrile, which makes it clinically a little bit tricky, but all of these kids were young and less than 29 days old. Interestingly, they identified a lot of blood cultures that came back positive for contaminants, and it was actually 10 times more likely that you get a contaminant blood culture that came back positive as opposed to a true blood culture. So the authors thought that perhaps we could move away from doing full SBI workup in kids, particularly the older kids, older than 29 days old with mastitis. And then a lot of the majority of local cultures that were sent came back positive for MRSA, to just keep in mind to cover for MRSA, particularly since that's not typically part of our neonatal fever bacterial coverage. So if we switch out of the bacterial infection world and jump into the viral world, this was an Annals paper that came out this past academic year looking at Ondansetron in kids with gastroenteritis. So this was a secondary analysis of a probiotic study looking at probiotics and diarrhea that was reanalyzed looking at Ondansetron in kids with gastroenteritis, vomiting, and diarrhea, aged 3 to 48 months. And they were looking at their primary outcome was reduction in IV fluids during an index ED visit, or alteration in vomiting and diarrhea over the course of the illness. Their secondary outcomes, we're looking at demographic data to help us understand this problem a little bit more. This is going to be a little bit of a busy results slide. You'll see down the middle, they did an unadjusted analysis, but I want you guys to look to the right where they did a propensity matched analysis, where they matched kids mostly based on illness severity for their gastroenteritis to see what would happen. And the top line there, the only thing that they found to be statistically significant after oral ondansetron was there was a reduction in IV fluids during the index ED visit if a kid got oral ondansetron. They looked at what happened over the next 72 hours returning to the ED to get IV fluids, hospitalization at the index visit, or in return to the ED, and none of these other things were found to be statistically significant. So the take home from this is that oral ondansetron in the ED for these young children, 3 to 48 months, decreases IV fluids at the initial ED visit, but does not seem to change outcome otherwise, which is really interesting. And you might be having flashbacks to a paper from a year earlier, also in Annals, that looked like this, that we talked about oral ondansetron for kids to go home from the emergency department, which is kind of a bonus paper reminder. And a reminder that this paper saw that if kids went home with a prescription of ondansetron, older kids, 6 months to 18 years, so a little bit different, these kids had a reduced likelihood of coming back to the emergency department, and there was no masking of symptoms. So maybe these two papers together can paint a whole picture that oral ondansetron in the emergency department might help decrease IV fluids in the emergency department, but if they go home with a prescription, it might prevent them from coming back. All right, so Dr. Samuels-Kalo.
So we're gonna finish by switching gears just to talk a little bit about trauma, and particularly about this clinical decision rule to predict abuse in young children based on bruising characteristics. So this is summarizing a prospective cross-sectional study that was conducted between 2011 and 2016 across 5 children's hospitals that enrolled kids who were less than 4 years of age who presented with bruising. And their primary exposures were looking at the bruising characteristics, the patterns, the counts, so how many bruises you had and how old the kids were. And the outcome was abusive versus non-abusive trauma as determined by an expert panel. And obviously one of the limitations of this kind of child abuse research is that there's no gold standard diagnosis for figuring out whether or not it's child abuse, and so this type of expert panel is pretty common in these studies to try and figure out what the right outcome is. And when you look at this graph, you can see that there's enormous difference between the patients who are determined to be abused, described in orange, and the patients who are determined to be non-abused, described in blue, between the locations of their bruising, with the biggest gradations being seen in like the buttocks and the neck area. And so as they were starting to put that data together, they used binary recursive partitioning analysis and came out with this rule. And I really want you to think about, this is a very challenging mnemonic to remember, that 10-4 faces rule. So we put up this picture to try and help kind of make a visual reminder for you. But it's trying to think about the regions, the ages, and the patterns of bruising. And we've talked for many years about the fact that pattern bruising should raise concern for child abuse. And I don't think that's a surprise to anyone in this group. But the age piece was important, that kids with 4 months of age or younger with any bruise anywhere should raise concern for child abuse. And then in particular, this issue of the regions was novel that came out of this work, that these particular regions, the torso, the ears, the neck, and then these faces regions, frenulum, angle of the jaw, fleshy part of the cheeks, eyelids, and subconjunctiva, the whites of the eyes, those were all injuries that were suggestive of physical abuse and warranted further workup.
All right, we're gonna skip through this article and go to our last two. So the last two articles that we selected kind of in the trauma theme, this one was published in JAMA Pediatrics late last year, and it was the evaluation of emergency department pediatric readiness as outcomes among US trauma centers. I personally really like this study because practicing in a non-tertiary pediatric trauma center, but one that does both, this is a really nice sort of elegant way of looking at outcomes for pediatric readiness, as there's not a lot of data on the outcomes related to pediatric readiness so far. This was a retrospective cohort study. They pulled patients from 2012 to 2017. They included patients presenting to 832 emergency departments located in trauma centers in the United States, basically all 50 states and the District of Columbia. And they included patients that were either admitted, transferred, or died. The part about this study that is really sort of robust is how large their sample was. They ended up with close to 372,000 children in this study. Their exposure was pediatric readiness for that emergency department using the pediatric readiness score from 2013. The outcome was in-hospital mortality or complications. I'm going to skip through that because unfortunately the notes aren't in there for that piece too. The bottom line of this study, so the piece that really came out is what they looked at was pediatric readiness by quartile. And then they did sort of this best fit factorial polynomials and really looked at pediatric readiness overall. What their study showed was that hospitals with a weighted pediatric readiness score greater than 90, so it's a scale of 0 to 100. So hospitals with a higher pediatric readiness score greater than 90, or it was the highest quartile being 93 to 100, actually had reduced mortality for their pediatric patients overall that came into their hospital. In addition, they also had reduced mortality for patients that had higher injury severity scores, higher abbreviated injury scale, both for any injury and for head injury. So what they showed essentially is that pediatric ready hospitals are associated with improved survival in our pediatric trauma patients. And this paper is a really kind of call to arms for making sure that we have very pediatric ready trauma centers. They estimated that of all of the children that presented over those 5 years, there were roughly 5,700 deaths. Of those patients that died in the lower quartile hospitals, so those unpediatric resi hospitals, approximately 126 of those children would have survived if they had been at a higher pediatric readiness emergency department to start with. So this paper is really impactful in how we think about our emergency departments overall and their pediatric readiness. The last paper, and this is just a quick bonus paper because it's a personal interest of mine. So this is the effectiveness and safety of TXA in pediatric trauma. This is a nice systematic review and meta-analysis. Essentially, what they did is they pulled TXA in trauma patients, any child less than 18 years old. They excluded case reports, included case series, and they did a meta-analysis using a random effects model. What they did is they looked at over 4,000 papers. They scoped it down to 14 that applied to this category. And then they looked at survival benefit with those papers. And they split them into combat scenarios and non-combat scenarios. So basically, combat versus civilian. What they found was in combat environments of the papers that had more mortality outcome, pediatric patients that were exposed to TXA had improved survival. But again, only in a combat environment. Of the studies that were, and all of these were observationally included in this meta-analysis, patients that were in a civilian trauma environment and exposed to TXA had no survival benefit. There's really no benefit to the TXA. They did look at sort of negative outcomes, so your thromboembolic events, this sort of reported seizure phenomenon, other things, and showed that there was no difference in those outcomes based on exposure to TXA. So basically no harm, but at least from this analysis, probably not super helpful in a civilian setting. That being said, this paper is a nice sort of call to arms for hopefully the upcoming PCAR and TikTok studies that will be done. That they're in the kind of final throes of funding to look at a randomized controlled trial of TXA exposure to pediatric trauma patients and actually answer this question in a prospective analysis to see if TXA has a mortality benefit to our pediatric trauma patients. All right, that is last of our articles. Yes?
Quick question.
Uh-huh.
For the combat environment that pediatric patients are found in, is that talking about like war-torn areas?
It is. So so it was Afghanistan, Israel, a handful of other countries. The injury patterns were different, more blast injuries, less sort of the blunt trauma that we think of within the United States. And so that was sort of part of the reasoning behind why there's the logic behind the possibility of why there's actually a survival difference. So it's a great question.
Do you think that difference could also be timed in definitive care? I know it's been brought up a lot in crash.
Yeah, it actually has been, and it's possible to. Again, these are observational studies. There's no prospective cohort, and there's a lot of, as you have with all observational studies, a lot of room for bias, selection bias in, as for also just and how the data is reported, plus sort of unmitigated, unmeasured bias. So yeah, it's entirely possible because those weren't all accounted for. Yeah, it's a really good point. So, all right. Thank you guys.